Welcome to This Explainer. If you're a pharmacy or medical student, you already know that neuropharmacology can sometimes feel, well, incredibly dense. But today, we're going to completely demystify it for you. We are setting the stage for a high-yield, structured dive into the clinical mechanics of Parkinson's disease. So, let's jump right in. I want you to really anchor yourself to the stark clinical reality of this disease. Imagine waking up one day and noticing just a slight shake in your hand. Then, a few months later, your handwriting is shrinking. Just walking to the kitchen takes immense effort, and your face feels entirely frozen, even when you're incredibly happy. What if I told you that losing just one tiny chemical in your brain could make all of those everyday actions feel completely impossible? But more importantly, what if we had the medical tools to temporarily bring those movements back? Here is our roadmap for today. We'll be looking at recognizing the clinical picture, the great brain imbalance, the pharmacological arsenal, long-term complications, and finally, the ultimate exam trick. Section 1. Recognizing the clinical picture.
To treat a patient, you obviously first need to recognize them in the clinic, or, let's be real, in a clinical vignette on your board exams. For Parkinson's, absolutely everything comes down to one famous four-letter mnemonic, TRAP. The T stands for tremor. Now, what's really interesting about this specific tremor is that it's not a shake that happens when you're reaching for a cup of coffee. It's a resting tremor. It usually starts in just one hand while the patient is sitting completely still. The hand actually looks like it's rolling a tiny pill between the thumb and fingers, which is exactly why it's universally known as the pill-rolling tremor. It's a massive cardinal early sign of the disease. Moving right along to the R, we have rigidity. We're talking severe muscle stiffness here. If you're examining a patient and you physically try to move their arm, it won't be a smooth, gliding motion. It feels exactly like turning a stiff, clicking gear wheel. It literally catches, then releases, catches, and releases. That is why neurologists and absolutely your exam boards will always describe this specifically as cogwheel rigidity. Next up, the A stands for akinesia, or bradykinesia. This simply translates to the absence or the extreme slowness of movement. This is exactly why even simple everyday activities start taking much, much longer. Patients develop this slow, shuffling walk. Their handwriting becomes almost microscopic, a clinical condition called micrographia. And dramatically, their facial expressions just sort of decrease, leaving them with what's known as a masked face. Finally, wrapping up the mnemonic, the P in TRAP is for postural instability. As the disease inevitably progresses, the patient's balance becomes incredibly poor. They lose those automatic, natural reflexes that keep us upright when we get bumped or lose our footing. This leads to frequent, very dangerous falls. And honestly, it's a major factor in the sharp decline of a patient's quality of life as the neurodegeneration advances. Section 2. The Great Brain Imbalance. Okay, so we've seen the physical reality, tremor, rigidity, akinesia, postural instability. But why is this happening? Let's zoom way in, deep inside the brain, to find the biological culprit. Parkinson's is a progressive neurodegenerative disorder. That means certain brain cells are just gradually dying off over time. Specifically, the cells taking the hit live in a tiny region called the substantia nigra. These exact neurons have one major, absolutely crucial job: producing dopamine. Dopamine is the brain's critical movement messenger. So when these substantia nigra neurons die, dopamine production essentially halts, and the body's entire movement system begins to systematically malfunction. Let's make this really concrete. Imagine you're driving a car. To move smoothly down the road, you need a perfect, coordinated balance between the accelerator and the brakes. Inside your brain's movement center, dopamine acts like the accelerator, and another chemical, acetylcholine, acts like the brakes. When those dopamine-producing neurons die, you completely lose your accelerator. But your acetylcholine brakes? Yeah, they are still fully engaged. The result? Your body is essentially trying to drive with the parking brake pulled all the way up. That's exactly how you get the slow, stiff, difficult movements of Parkinsonism. So, a logical question is, what's actually killing these neurons? Well, while the exact cause remains a bit of a mystery, scientists know it's a combination of factors. We're talking aging, genetic mutations, environmental toxins, and oxidative stress. They all play a role. But the major pathological hallmark you absolutely need to know for your exams is the formation of Lewy bodies. These are abnormal protein deposits that just build up inside the neurons, severely damaging them and ultimately causing their death. Section 3. The pharmacological arsenal. Now that we know the core problem, a critical loss of the dopamine accelerator, we can start building our pharmacological arsenal. And our entire treatment strategy here is surprisingly simple. We just need to restore that broken biological balance. But wait, if the patient is out of dopamine,
Your most logical first thought is probably, why not just give the patient dopamine directly, in a pill or an IV? I mean, it seems so obvious, right? But there is a massive biological roadblock standing in our way. Here is the crucial point. Dopamine simply cannot cross the blood-brain barrier. It is completely locked out. But its chemical precursor, levodopa, that absolutely can. Levodopa basically acts as a Trojan horse. It sneaks right across the blood-brain barrier, and once it's safely inside the brain, enzymes convert it directly into dopamine. This replenishes the depleted levels and dramatically, almost magically, improves the patient's movement. Because of this amazing ability, levodopa is the absolute gold standard for Parkinson's. But it has a major, major flaw. If you just give levodopa on its own, a huge chunk of it gets converted into dopamine while it's still out in the bloodstream, way before it ever reaches the brain. And dopamine floating around in the bloodstream, that causes severe nausea, vomiting, and hypotension. To stop this, we always pair levodopa with carbidopa. Carbidopa chemically blocks that early conversion in the body. It acts as levodopa's personal bodyguard, taking the hits in the bloodstream so that the levodopa can safely reach the brain intact. Okay, let's see how this builds out our broader therapeutic strategy. Once we finally get that dopamine into the brain, we want to keep it there for as long as possible, right? The brain naturally has these enzymes, specifically MAOB and COMT, that break dopamine down. So we use inhibitors. MAOB inhibitors like selegiline stop the breakdown of the dopamine we just worked so hard to create, and COMT inhibitors like entacapone stop the breakdown of levodopa itself out in the periphery, effectively making every single dose of levodopa last much longer. We are essentially chemically protecting our investment.
The rest of our arsenal gives us a few more clever ways to manipulate the balance. Dopamine agonists, like pramipexole, basically act like fake dopamine. Even if the natural dopamine is completely gone, these drugs directly stimulate the receptors anyway, which is a great strategy for early-stage disease. Next, we have anticholinergics, like benzotropine. These attack the other side of the equation. Remember the brakes? These drugs reduce acetylcholine activity to take the brakes off, which is particularly useful for managing those resting tremors. And finally, imantadine. This is a highly unique drug that actually increases natural dopamine release and is famously used by clinicians to manage the side effects of levodopa.
Section 4. Long-term complications.
Speaking of side effects, while levodopa is undeniably a miracle drug, it comes with a very steep price tag over time. After years of levodopa treatment, major unavoidable adverse effects will appear in almost every single patient. And if you are taking a pharmacology exam, consider these 3 bullet points, guaranteed questions. First, patients develop the wearing off effect, where the medicine abruptly stops working before their next dose is even due. They also experience the on-off phenomenon. This means they suddenly, completely unpredictably, switch back and forth between having great mobility and severe immobility. And finally, dyskinesias. These are uncontrolled, involuntary, writhing movements caused by the medication itself. It's a really tragic irony that the drug we use to restore fluid movement eventually causes involuntary movement.
Section 5. The ultimate exam trick. So, we've covered the symptoms, the brain biology, the drugs, and the side effects. Let's tie the whole shebang together with the ultimate exam trick. This is your absolute foolproof study hack for recalling Parkinson's pharmacology on the fly. I want you to literally burn this formula into your memory. Whenever you see a clinical vignette mentioning a resting tremor, cogwheel rigidity, or the word Parkinson's, immediately write this down. Parkinson's equals decreased dopamine plus increased relative acetylcholine. Really let that sink in. Because if you know that every single treatment answer on your test must either aim to increase dopamine or decrease acetylcholine. Everything in Parkinson's pharmacology revolves perfectly around this one core principle. Parkinson's disease is a quiet, devastating battle happening deep inside the brain. It robs patients of their autonomy by deleting just one single microscopic messenger. But through the incredible science of pharmacology, we found a way to fight back, to brilliantly restore the balance of the accelerator and the brakes. Ultimately, Parkinson's pharmacology isn't just textbook science. It is the art of bringing dopamine back. And honestly, it really makes you wonder, doesn't it? What other fragile chemical balances in the human brain are just waiting for us to decode and restore? Keep that in the back of your mind as you study. See you next time.